Good morning, guys.
Morning.
Good
Morning.
morning. Okay, so we're going to be discussing um, the EP program here at Northern Westchester, which is going to be launching in a few weeks. So some objectives for the session, which should not take long. We're going to describe the program, the EP program here at Northern Westchester. We're going to describe what an EP study is, discuss what a frequency ablation is, discuss the various types of devices that are going to be implanted in the EP lab, and discuss the complications and implications for the ED. So, EP program at Northern Westchester, we will be launching our EP program on this January 12th, so just in a few weeks. Um, Dr. Subbarao Chowdhury is the director of EP services here at Northern Westchester. We do have an associate director, but he's not going to be starting until June of 2021 because he's actually finishing up his training at Columbia. EP and CAF, we will share the procedure rooms. So we're gonna, the two labs right now that where we do catheterizations, we're also going to be doing the EP cases in there. Mondays and Tuesdays are the designated EP days, which just basically means the doctors will have like block time, and that's subject to change. CAF EP RNs will assist during the procedures. They're going to, assist during the procedure with the physician and also care for these patients pre and post-op, as well as the ACP. So basically what that means is the same nurses that are currently doing CAF and the ACPs are also going to be doing EP. Okay, so EP procedures are really typically elective in nature. There's really like no true emergencies. The only one that I can think of, or really that exists, is really third degree heart block, which and we're going to discuss, third degree heart block a little later in the presentation, but that's really the only true EP emergency, and we're going to discuss how we're going to be handling that going forward when we start the program. Cardiology will continue to be consulted for patients requiring EP services. So unlike, a patient coming in and there's possibility of the patient needing a catheterization, we call the CAF ACP or the physician to consult. That won't happen with EP. We're still going to be calling cardiology, which is what you currently do. So there's no change there. And then EP patients that present to the emergency room most commonly are going to be those with post-procedural complications. And we're going to discuss those as well. So EP procedures, what are we going to be doing? So in the lab, we'll be doing EP studies, which is very similar to like a diagnostic cath where we're kind of in the heart and we're trying to figure out what's going on. We're trying to diagnose the issue. Radiofrequency ablation, which I'll discuss as well. We're only going to be doing right-sided ablations, which means we're not going into the left side of the heart. We don't need to. We're not going to be puncturing the septum, so we're not going left-sided, and we'll discuss that as well. Device implants, lead revision, so those include our pacemakers, our ICD defibrillators, implantable defibrillators, loop recorders. Those are all the implants, and then we're going to also be doing cardioversions. Okay, so when we talk about an EP study, as you already know, with a catheterization, we're really looking at the coronary arteries, which are really outside of the heart. And I would have to change my screen, right? They can see? Okay. Can you guys see this?
Right now, I just have EP study.
Yeah, well, I have to change my screen.
You don't see Alba and I?
No.
All right.
I see you guys.
You do? All right. Hold on. Marty,
do you see the picture of the heart that she's holding up? Or
Yeah.
You see that? Okay. So I just want to pull this, because I have these little gadgets, so I want to use them. So if you know, obviously with the catheterization, we are on the outside of the heart. So we're really in the coronary arteries, right? So
Yep.
with EP is different because what we're doing is we're actually on the inside of the heart. And it's not anything that you can see. We're talking about the electrical conduction system, which is, starts at your SA node and then goes to your AV node. So we're in the right atrium. and the signal is conducted down into the sinus, from sinus to the AV, to the bundle of pith, to the right and left bundle branches down to the Purkinje fibers. So it's nothing you can see, but one of the big differences is that cardiac cath, we're dealing with coronary arteries outside of the heart, and electrophysiology, we're really dealing with the conduction system inside of the heart. Okay? So with an EP study, like I said, what we're doing is we're really, it's a diagnostic procedure. We're trying to figure out what's wrong. And essentially what we're doing is we're looking at where an electrical impulse comes from, where it goes, and how it gets there. And that's important because when we monitor that electrical function of the heart, we can also stimulate impulses via a catheter. And when we do that, it helps create a map. And that map, you'll hear that very commonly in EP, that we're using a mapping system, and we're really mapping the electrical signals of the heart. And that's important because once we're able to map out where the signals are coming from, or like a problem area, we're then able to ablate it. Okay, and then when we do that, after we map out that area, right, the physician can determine that we're going to conduct a radiofrequency ablation, or an RFA. And what an RFA is, when we have catheters in the body, the distal tip of that catheter is heated to a certain temperature. And that catheter is basically touching the tissue inside the heart. And when we turn it up, when the heat, when the temperature is raised, we're actually burning that area. We call it an ablation. And what we're doing is we're destroying that problem area of those cells. And when we do that, we create a scar. And the goal is that if we create a big enough scar, then the electrical signal can't conduct past that scar. So that's really what we're doing when we do an ablation. And there's other types of ablation that exist. There's something called a cryoablation, which we won't be doing here, but just so for your information, it actually uses very cold temperatures as opposed to heat. And that also can destroy the cells. It also creates a scar tissue. I mentioned a little earlier that we're only going to be doing right-sided ablations here. And the reason for that is we don't have cardiothoracic surgery at this hospital. And it's similar to cath in that for high-risk PCIs or coronary interventions, right, we can't do them here. Something like a left main artery, we really can't fix those because it's such a high risk. That's the same thing with EP. We really don't want to go to the left side of the heart because when we do that, it's considered high risk, and we would need surgery backup, which we don't have. I'm going to pause there for questions. Okay. So moving on, aside from ablations, we're going to be doing device implants, which we currently do now. As you know, we do implant pacemakers in the OR. So we're going to be doing this in the lab, in the EP lab. Some reasons for pacemaker implant, as you know, symptomatic bradycardia, sick sinus syndrome, complete heart block, and pacemakers can also help treat patients that are in heart failure. As far as implanted cardiac defibrillators, so it's exactly what it sounds like. It's a defibrillator, but we implant it. And actually, hold on, I have these here to show you. So this is, I'm going to hold them both up. This is actually a defibrillator. And if you notice, this is a pacemaker. If you can notice the difference in the size, and it makes sense. This has to be bigger because this is actually going to shock the patient out of a lethal arrhythmia, while the pacemaker is just going to pace the heart. Okay, so these are the actual sizes of the, these are the generators. So when these are implanted, obviously they get attached to leads, but this is what goes into the pocket. Defibrillators are implanted to prevent sudden cardiac death in patients with known sustained VT or ventricular fibrillation, like in Brugada syndrome. They also prevent cardiac arrest in high-risk patients who haven't had but are at risk for life-threatening ventricular arrhythmia. So like patients who've had a massive MI and whose ejection fraction is now is low, they would need an ICD. Okay. Um, loop recorders. Thank you. Loop recorders. I actually have a loop recorder here. You see, they're very tiny. So this is actually a loop recorder here. Um, and what this is, it's actually, just think of a Holter monitor. It's exactly what it is. The Holter monitor that we put on externally, this is actually an implanted version of that. And we need that because, you know, there are times when a patient will present and say, you know, I'm having palpitations. And obviously when we do an EKG, let's say they're in normal sinus rhythm. So the loop recorder really captures information that an ECG or a Holter monitor can miss due to the abrupt starting and stopping of an arrhythmia. And that can be it's implanted and it can continuously record the heart rhythm for up to 3 years. And it's a very quick procedure. They actually do them in doctors' offices. It's done under local, obviously a sterile technique, but it's implanted within minutes, and the patient goes home the same day. Cardioversions, direct current cardioversions. We know what this is, right? We do them in the ED all the time. Electrical shock, it's delivered to the heart to convert or change an abnormal heart rhythm back to sinus. Now, currently, what you do in the ED, that's not going to change. If the patient is coming in and needs emergent cardioversion, you're going to still be doing that. What we're going to be doing in the lab are more elective cardioversions, and those are patients that are in AFib or patients that are in a flutter. And really, for those patients, we need to confirm the last dose of anticoagulation. And this is a nice to know for the ED, but if, a patient presents AFib, a flutter, and they're going to be cardioverted in the lab, something for you to be mindful of, we got to make sure that we have to confirm the last time they took their anticoagulation, because even one missed dose of Pradaxa, Xarelto, any of these anticoagulations, we'll either stop the procedure, like postpone it, or we need to get a TEE, a transesophageal, because we need to make sure that there's no clots in the heart, because if we were to shock them and there's a clot, we can give them a stroke. Okay. Questions so far? Okay. So surgery-free heart block. I mentioned earlier that there's really no true emergency. This is probably the only one that you will see in the ED. And you're going to treat as you normally would. You're going to, put some pads on the patient, transcutaneously paste them. But the difference now is that because we have the EP lab, we can actually bring the patient up to the lab to put in a transvenous pacemaker. So what we're thinking the flow of that will look like is that the ED provider is going to consult cardiology again, and if the decision is made to place the transvenous pacemaker, the temporary wire, the ED provider is actually going to contact the interventional cardiologist, kind of like the same way if there's a STEMI. They're going to contact the interventional cardiologist on call. Now, this is during off hours, and they're going to activate the call team, and the call team is going to come in. And under guided fluoroscopy in the lab, under X-ray, we're going to put in that wire, the temporary wire, so that we can transvenously pace the patient until we can put a permanent pacemaker into the patient. Okay. During on hours, kind of the same thing will happen. We'll contact the ACP. We'll contact the provider, and basically the ACP is going to coordinate placement. Is going to coordinate the transvenous placement in the lab, similar to what they do now as far as coordinating, STEMIs to go to the lab. They're going to coordinate that. One important thing, which I did mention this before, but the cath lab, EP lab, ACPs, they're not going to be performing consults again. So if there's a patient that is requiring EP services, we're going to consult cardiology the way we do now. Okay. All right, so EP complications. So I kind of, when I created this slide, I set it up into kind of both. I divided it up into the complications that you most likely would see with an implant, device implant, and an ablation. As you can see from the screen, as far as the device, we'll see complications will be bleeding and pocket hematomas. Like, that's common for the patient to come back. Well, hopefully not. But if we don't apply a pressure dressing and the patient continues to bleed, they can develop a pocket hematoma. So that's something you may see in the ED. The patient can come back with an infection, endocarditis, pericarditis, PEs, pneumothorax, pericardial effusion. I put those towards the bottom because those are complications, but we're more likely to see those like following like more immediately following the procedure. So these patients, when we implant these devices, they are going to be spending the night with us. They stay one night. The next morning, they do need an x-ray to make sure that none of the leads dislodged and that everything's okay. And then we send them home. So we're more likely to find, a PE or a pneumo or a pericardial effusion tamponade within that time frame as far as the device. As far as an ablation, radiofrequency ablation, again, vascular complications like the bleeding in the hematoma. Remember, it's similar to cath in that we've accessed the groin area, venous thrombus, retroperitoneal bleed, retroperitoneal bleed because of the stick, depending on where the physician punctured the groin. If it was a high stick, it can predispose the patient to retroperitoneal bleed. AV node damage. Now, this is important because I mentioned in an ablation, what we're doing is we're creating scar tissue, right? We're burning the tissue. And sometimes if the physician is too close to the AV node, we can actually damage the AV node. And then we've kind of fixed their arrhythmia, but now they need a pacemaker. But the physicians are aware, when they're very close to the AV node, but just know that that's something that can happen. Also, infection, pericardial effusion, and tamponade. And again, the pericardial effusion tamponade we're more likely to see that immediately following the procedure, because again, these patients do spend the night with us after an ablation. So just looking at that slide, there's a complication that's not on there. That is, I'm just curious if anyone can pick that out. That is more common in like a cath procedure, but not so much for EP. Can anyone figure that out? No? Okay. Stroke. So if you notice, I don't have stroke on here. And really, because I mentioned we're on the right side of the heart, we're not on the left side, the risk of stroke is less likely. If we were doing, let's say, an AFib ablation where we have to go transeptal, we're going from the right side to the left side of the heart, we place the patient. The patient is more at risk of having a stroke, but because we're not, the risk is less. So I just wanted to point that out. Does anybody have any questions? Like a blackout.
Okay. I'm going to stop the recording. And if you have questions still after, you can feel free to unmute and ask. If there's no questions, we're going to let you guys go, and we'll be sending out this recording to the staff for everyone else to see it when we're done with this.
Thanks, ladies. Great job.
Thank you.
Thank you.
Sounds good.
All right.
Thank you.
Thanks, Casey. Thanks, Marty.
Bye.
Bye.
Bye.